So I have no financial disclosures. And this is where I'm from, St. Joseph's Regional Medical Center. It's also where our incoming president, Dr. Savando, is from. It's in Paterson, New Jersey. For those who don't know, we see over 160,000 patients a year at a single location. We're a level 2 trauma center. And it's been reported that we have in Paterson some of the purest heroin in the nation. I don't know if that's true, but relevant to our talk. So I'm an emergency physician. I'm actually a fellow. I'm doing a fellowship in pain management, ER-focused pain management. And I know that there are a lot of different types of physicians here. So a lot of my cases are, ER cases, but some of them may be situations that you can apply in your practice. And we'll briefly discuss the current opioid epidemic. So I like history, so we'll briefly go over the history of opium, morphine, and heroin and how it kind of relates to where we are today. So in 1804, a German pharmacist named Frederick Sir Turner isolates an alkaloid from opium and calls it morphium after the Greek god Morpheus, for Greek god of dreams, because this alkaloid put people to sleep. In 1827, Merck and Company markets morphine commercially after a French physician publishes a paper about using morphine in one of his patients who had a great deal of pain relief and improved sleep. In 1853, Alexander Wood was a Scottish physician. He invents the first hypodermic needle solely for the purposes of injecting morphine. In 1897, Hoffman and Dresser of Bayer Company synthesized diacetylmorphine, thinking that it had less side effects than morphine and less addictive, and it was very effective for cough. And at that time, tuberculosis was very rampant. And so they tried it on their workers, and their workers stated that it made them feel heroic, and so they called it heroin. In the 1900s, free heroin samples were sent by mail to morphine addicts to help them quit. In 1905, Congress bans the use of opiates in the U.S. In 1924, the Treasury Department's Narcotic Division banned all narcotic sales, and this kind of the market for heroin and opium in the underground market starts to flourish and becomes a source of profit for organized crime. In 1973, the DEA is formed. And then in 1980, Drs. Jane Porter and Herschel Jick wrote a commentary to the editor in the New England Journal of Medicine titled Addiction, Rare in Patients Treated with Narcotics. And they basically looked at their patient census, the patients that were admitted who were given narcotic medications, roughly 12,000 patients. They stated that only 4 of them became addicted. And they concluded that despite widespread use of narcotic drugs in the hospitals, the development of addiction in patients, medical patients with no history of addiction, was rare. So that article ends up being referenced in the later decades after 1980 multiple times in Time magazine. NIH references it to support the use of opioid medications in patients, and then the fifth vital sign, pain became the 5th vital sign, and it was believed that we were under-treating pain. 6th. So I already gave away the answer, but the nationally prescribed medication number 1 from years 2007 to 2013 was Vicodin. The last set of data that I've seen from 2015 shows that Vicodin is number 3 around 2015. But for 7 years, it was the nationally #1 prescribed medication above lisinopril, above levothyroxine, very common medications. How many adolescents between ages 12 and 17 years are estimated to be addicted to prescription opioids? We estimate it to be about 168,000 currently. And where are they getting it from? From the medicine cabinets of family members, friends, and some more numbers. So 1.9 million estimated people are dependent on opioid pain relievers currently. 75% of people who currently use heroin or some illicit opioid, they state that it started out with the prescription opioid medication. 51 people die per day from prescription opioid overdoses, and if you total that at the end of the year, it becomes 18,893 deaths per year. This is just prescription opioid overdoses. If you look at 2016's data for total opioid overdoses, including prescription opioids and illicit opioids, it's 33,000. And obviously when heroin costs $2 to $5 a bag in Patterson, it's so cheap. You can see how when people, for whatever reason, cannot get prescription opioid medications anymore, they may resort to heroin. So the heroin epidemic, the opioid overdose epidemic in the United States, the death rate resembles that of a new infectious disease. So if you look at the graph on the left, that's the death rate of HIV/AIDS when it was rampant in 1983 to 1990. The graph on the right, or the left actually, is the death rate of the prescription opioid overdoses from 1990 to 2015. The orange line is the death rate in the Caucasian population, and the green line is the death rate in African American and Hispanic populations. And what we think has been happening is that physicians have been discriminating against prescribing opioid medications to those populations, thinking that maybe they're more susceptible to abuse, and you can see it's reflected in the death rates. And actually, the Caucasian death rate has been higher. I don't have the y-axis here, I apologize, it didn't come up, but this is basically a graph showing how as opioid prescriptions increased over the past couple of decades, so have the opioid overdose deaths. So we consume 80% of the world's morphine, but we only make up 5% of the world's population. And really, heroin, is a problem, a big problem, but there's an even bigger problem on the horizon, and that's fentanyl. And fentanyl is being used to lace heroin, to make it more potent, and sometimes fentanyl is being sold as pure fentanyl on the streets. Fentanyl is 100 times more potent than morphine and 50 times more potent than heroin. It's cheaper to make than heroin, and it's easier to transport because it's more potent, so there's less of it that needs to be transported. Another problem is carfentanil. A lot of medical examiners are finding carfentanil, which is it has been previously used to sedate large animals. We're talking cattle, elephants, and they're finding it in overdose deaths. When I gave a lecture in Wisconsin, I spoke to an emergency physician there, and he said that he had a young 20-something-year-old patient came in cardiac arrest who required 20 milligrams of Narcan before he had return of spontaneous circulation. So that's, we're not seeing as much in Patterson at this moment, but in other parts of the country, they are seeing this, and it's a big problem. And I spoke to an ER physician yesterday in Pittsburgh who told me that for all of their cardiac arrests, now they are required to send off tubes of blood to check for some of these substances, carfentanil, fentanyl. And carfentanil happens to be 100 times more potent than fentanyl. So what can we do as physicians? We can keep our opiate-naive patients opiate-naive, okay? Especially when they have chronic pain conditions, so something like herniated discs, something that they're going to live with for a long time. We can reduce exposure. We can use alternative therapies to patients who are already opioid tolerant when they present to you with acute pain, and educate patients on managing their expectations of pain, telling them that we won't be able to take away your pain 100%, but we can reduce it to a level that's tolerable or manageable to you. And obviously educate them on the dangers of addiction. But a word on opioids. So opioids are necessary in the right patient. Obviously, if a patient comes to the ER with an open extremity fracture, now is not the best time to use an alternative, right? Or a cancer pain patient. But we just want our fellow healthcare providers to think before they prescribe, to use alternatives whenever possible, and to care about the patient. So at St. Joseph's, we created the ALTO program, and ALTO is an acronym for Alternatives to Opiates. It's a set of protocols that we developed treating specific types of pain that commonly present in the ER, and these are a couple of things that we've made protocols for. So renal colic, musculoskeletal pain, lumbar radiculopathy, migraine headaches, extremity fractures, and so forth. But for the purposes of this talk, I'm just going to touch on a few of them. So case 1, MM is a 57-year-old female who presents to the ER with severe flank pain, vomiting. She has a history of renal stones, and no past medical history, hasn't taken anything prior to arrival in the ER. Again, a lot of these cases are ER cases. And standard, treatment for someone who comes in with, renal colic, give them some Toradol IV, some normal saline, and Zofran. But, sometimes that doesn't work, and she reports minimal pain relief and is still in distress. The next line therapy, previous to us implementing ALTO, would have been morphine, 5 milligrams of morphine. And if that wasn't working, then another 5. And morphine can make you nauseous, so some more Zofran. And at this point, there's a failure of treatment. She's not getting better. So what kind of treatment can you provide her at this point? That's case 1, so keep that in mind. Case 2, Jay is a 28-year-old male, presents with severe kidney stone pain again. History of kidney stones in the past, but he's a recovering heroin addict, and he's been 7 months clean. And so you want to adequately treat his pain. You don't want him to suffer, but you don't want to give him something that's going to send him back into relapse. And he states that the last time he had renal colic, he was given morphine, and it took him months to recover from that craving for heroin. So what are the alternatives? Is there evidence to support the use of alternatives for renal colic? Well, there is, and not so much in the ER literature, but definitely in anesthesia literature, looking at intravenous lidocaine for intractable oncological pain and postoperative pain, showed to have fewer side effects compared to opiates alone, little to no toxicity when used appropriately, dosed appropriately, and improved quality of life. There was a Cochrane review looking at lidocaine for postoperative pain. Basically showed that there was immediately reduced pain lasting up to 24 hours. There less need for opiates, decreased length of stay, quicker bowel function return. We don't know if that's because we were using less opiates when introducing lidocaine. less nausea. But basically, there was low to moderate evidence that IV lidocaine impacted pain scores compared to placebo. But there are definitely more studies that need to be done. There's only a few studies in the ER literature looking at IV lidocaine in the ER, but definitely more studies have to be done. The mechanism of action, it inhibits the afferent sensory conduction, so that provides analgesia, and paralyzes the ureter. We don't know if this translates into quicker stone passage, but if you are going to give it, I don't know if there are any ER physicians here, but certainly anesthesiologists would know about this, but it should be given while the patient is on a cardiac monitor. It is a cardiotoxic drug, so it has to be weight-based dose. We give it a dose of 1.5 milligrams per kilogram, and we run it over 10 minutes on a pump. Anesthesiologists easily give 100 milligrams up front when sometimes intubating, so this is given over a period of 10 minutes. And with IV lidocaine, you should have intralipids on hand just in case there is any overdosing of the lidocaine. So take-home point 1, IV lidocaine is a safe and effective analgesic for renal colic. Case 3, 57-year-old male presents with 2 days of acute low back pain after moving a sofa. He's tried some ibuprofen, it didn't really help. What's the best treatment for him? So we know that opioids are not the first line, especially in the ER for back pain. Early opioid prescribing has been shown to increase rates of MRI, significantly associated with significantly higher medical costs. 29% more likely to, patients are 29% more likely to end up on chronic opioids when prescribed opioids early. And so we encourage a multimodal approach. This includes NSAIDs with Tylenol, with topical medications. We could employ trigger point injections if needed, gabapentin if there's a radicular component to the back pain, and plus or minus muscle relaxants. Studies have looked at NSAIDs and Tylenol showing that there's a synergistic effect when using the two combined. We recommend using a full gram of Tylenol for a patient 55 kilograms or over. And their studies also show that that ibuprofen has an analgesic ceiling of about 400 milligrams. So beyond 400 milligrams, you're not going to get much of an increase in analgesia. Topical patches are great. I use a lot of lidoderm patches in my patients in the ER. A Cochrane review looking at oral NSAIDs versus topical NSAIDs, for example, diclofenac patches or diclofenac gels, showed that they were equally as efficacious, great to use in muscle sprains, strains, so forth. And it might be a really great agent for you to use if the patient has a history of peptic ulcer disease or an older patient that you don't want to introduce a whole lot of NSAIDs to. There is some systemic absorption, but not as much with topicals. And trigger point injections, does anyone in here ever do trigger point injections? A few people, okay, good. So, I've done probably about 30 in the ER, and I've had really great results. It's basically targeted analgesia, so if a patient comes in with muscular back pain and they have a very easily identifiable area of taut muscle spasm, you can take a syringe with a 25 gauge needle and drop a couple of mLs of Marcaine, locate the spasm, dry needle it, and inject the Marcaine. And it's very effective. The theory is that the dry needling breaks up the muscle spasm, and the Marcaine is really just to provide relief from muscle soreness from injecting. I did include a YouTube video, but I'm not going to go through it here. But if you can definitely look it up on YouTube, there are tons of videos on how to perform these, and they're extremely easy. So, take-home point number 2, most acute low back pain does not require opioids. And I remember when I was a resident, like an intern, I remembered that before we started becoming more aware of, the opioid epidemic, and before we started, introducing alternatives, giving Percocet for back pain was a very common thing. And now in our ER, it's virtually unseen. So anyway, remember the multimodal approach to treating back pain. So NSAIDs with Tylenol, with topicals, plus or minus muscle relaxants if necessary, plus or minus gabapentin, and trigger point injections. Case 4, 57-year-old male with chronic pain due to lumbar radiculopathy. He presents with an acute flare, but he already takes MS-Cotton 100 milligrams PO BID and oxycodone as needed. So this is someone who's already tolerant, opioid tolerant, requires lots of medications to get his pain under control. You don't see any of the red flags associated with low back pain, so how would you manage him? So for our opioid tolerant patients, we start with the basics, NSAIDs, Tylenol, gabapentin, plus or minus muscle relaxants. But we also offer ketamine infusions. So ketamine, it antagonizes the NMDA receptor. That's what provides analgesia. We use it at a sub-dissociative dosing of 0.3 milligrams per kilogram for an infusion, and if they respond to that, you can continue with the 0.1 milligram per kilogram per hour drip. There is an opioid-sparing effect, so if you were going to use any morphine or Dilaudid, you could actually use less of it if using in combination with ketamine. And at these sub-dissociative doses, there aren't changes seen in vital signs usually, and no additional monitoring is necessary. So with ketamine, there's potential for mild transient dysphoria. You should prepare the patient for this, and tell them that there could be an emergence phenomenon. If there are any signs of that, you can prescribe benzodiazepines in the emergency department, but it's rare. And once the patient is better and they appear to be ANO times 3, you can safely discharge them to home. It's used in our ER a lot for pediatrics. We can use it intranasally, which is great. So if you have a pediatric patient, it's difficult to get an IV on. Could give a dose of 0.5 milligrams per kilogram with a max dose of 50. Again, I don't know the makeup of physicians here, but if you guys use atomizers, but anyway, there's no change in vital signs at this dose. Significant reduction in pain scores. It's easy to administer and redose, and it works within 15 minutes. So take-home message number 3, ketamine can be used in conjunction with opioids or as a sole agent for analgesia in the emergency department for acute pain. And intranasal administration is effective and easy. This is the last case. So a 23-year-old male comes to the ER for a gluteal abscess. So this is sometimes a situation that we find ourselves in, working in the fast track, and somebody comes in with a large abscess, and it's, in the fast track area, you don't really have monitors to put the patient on. So if you want to really, if you want to either sedate them or give them, large amounts of pain medication, you would prefer them to be on a monitor. So what can you do in this setting? So we have nitrous oxide in our ER. It's been used for decades in dental medicine. And it's a tasteless, colorless gas. It's administered in combination with oxygen via nasal hood or mask. And it's absorbed via the pulmonary vasculature and doesn't combine with hemoglobin or other body tissues. It has a rapid onset and elimination, works within 60 seconds. So it has analgesic and anxiolytic properties. You can use it with other pain medications. You can use it with other local anesthetics. It releases enkephalins as well, which we believe that may interact with opioid receptors. So if there's ever a thought or suspicion that the patient's receiving too much, you can reverse with naloxone. Only monitoring necessary is pulse ox. And there aren't any NPO requirements, and they can drive after administration, and no IV line is needed. So these are a list of the procedures in which you can use nitrous oxide. And the only, the downside to nitrous oxide is that there is a potential for abuse. In our ER, we don't have it locked up, but however, we do have our ER. We have surveillance cameras everywhere, so I don't know if that's a deterrent, but we haven't had any issues with recreational use. Our unit is mobile, so we can take it from room to room, and the patient has to be awake and alert and able to hold their own mask to their face. So contraindications of using nitrous: you don't want to use it in anyone with severe lung disease, so you can't use it in anyone with a pneumothorax, COPD, severe asthma. It depletes your vitamin B12 stores, so if they have a history of that, obviously you can't use it in those patients. Any areas with pressure changes, so otitis, anyone with otitis media, sinusitis, or bowel obstruction, those are not good candidates. No one with an already altered level of mental status, and you cannot use it in first and second trimester pregnancy. But overall, we use it in our ER. It's been very effective. It's easy to use, and it's fast acting. So take-home point number 4, like I just said, it's ideal for management of acute pain. Another thing I won't go into too much depth, but I am really excited about is ultrasound-guided regional anesthesia, which is a technique that really is only used by, at this point, anesthesiologists, and ER physicians are starting to become trained in this and starting to employ this in the ER. As part of my fellowship, I'm trained by a anesthesiologist who was trained in regional anesthesia, and I get 600 hours of training in this, which is great. So if we have a patient that comes into the ER with, let's say, an older patient, let's say she's 85 years old, has a hip fracture, and she comes in and she's in significant pain, but with hemodynamic effects of morphine and respiratory issues, giving her lots of morphine may not be an option. And so ultrasound-guided nerve blocks are great. If she's going to get admitted, and as long as you have a discussion with the orthopedic surgeon and he or she is on board, then they get very, very good pain relief for 24 to 36 hours and while they're waiting for their surgery the next day. So in summary, for renal colic, think IV lidocaine. For low back pain, think of a multimodal approach: Tylenol, NSAIDs, topicals, trigger point injections. For opioid-tolerant patients, think about ketamine infusions in the ER. And for procedures, think nitrous oxide. So what are some of the barriers that we currently face today when trying to employ some of these alternatives, and some of the barriers that I face? That the stigma of addiction still exists. Patients that are addicted to what have you, Percocet, morphine, Dilaudid, heroin, they are truly addicted, and it's a true neurochemical change in their brain. It's not just a matter of will. So we really have to be, empathetic towards our patients, and when they come into at least from my end as an ER physician, when they come into the ER, instead of saying, I know you're drug seeking and I'm not going to help you, I'm not giving you any pain medications, just, get out. You can offer alternatives. There are alternatives, and if they're willing to try them, then, we can provide them with that. So most insurance companies do not cover inpatient detox programs for more than 28 days. So if you have, if there's a person who has been, addicted to heroin for years, 28 days may not be enough. And a lot of these patients go into these, or people go into these cycles of starting treatment and then not having their, they can't continue their programs for as long as they need, and they use and then they go back to detox over and over and over again. Most insurance companies don't cover topical medications, so that's a little frustrating. Sometimes when I start using some of these alternatives in the ER, like, lidoderm patches, they are mostly not covered by insurance companies, so that's an issue. But there are ways around it. For lidoderm patches, you can prescribe 5% lidocaine ointment. That's mostly covered by insurances. And something that I find a little bit backwards is that the cost of IV morphine, on average, for a 30 milligram syringe is about $16. Cost of hydromorphone or Dilaudid for a 6 milligram syringe is $21. However, the cost of IV Tylenol or Firmev is $35 per 1 gram vial. And today, when you have a huge opioid epidemic, this is really backwards, and it may kind of push hospitals to use the more cost-effective, medication as opposed to, using an alternative. So this took a huge collaborative effort in our hospital. We had to get all of pharmacy on board, nursing staff, hospital administrators, and also other physicians on board who have been used to prescribing a certain way for so long. But we have been very successful. We are currently doing a study looking at our own physician prescribing habits within the ER, looking at 3 months prior to the implementation of Alto versus 3 months after, and we've had a 48% reduction in opioid prescriptions. So what I do is I have had the opportunity to go around speaking to other ER physicians, ER nurses, and educating them on the possible alternatives that we have today to use. And I'm really optimistic about it. It's been really successful in our ER, and I think it can be successful in other ERs as well. So again, just to reiterate, we need to try to keep the opioid exposure to a minimum. Prevention is key. And, sorry, my clicker wasn't working. And we want to support our patients who suffer from the disease of addiction and educate our patients on the potential dangers of abuse. My colleague, Alexis, who did the fellowship before me, she, I don't know if there are any ER physicians in here, but she started the pain management section at ACEP, the American College of Emergency Physicians. So if anyone is a member of ACEP here, please join the pain management section. And if you have any questions, her email is at the top, La Pietra, and my email is at the bottom. And we'd be happy to answer them or share our protocols that we use in our ER with you. Thank you.